Welcome, everybody. Thank you for joining today. So this topic happens to be my absolute favorite topic in all of dentistry. And it's been something I've really been trying to work on and grow for about, almost 40 years. The first time I ever actually lectured on facially generated treatment planning was actually 1986. And a little bit of what was behind it is dentistry is an interesting profession in that the fact is you only treat what you see, and you actually only see what you know. And so the problem is, if you haven't been taught to see, then you have patients that come into your practice and you know something's wrong, but you don't know what to do about it. You don't know how to help them. And so I for a few years, have used this photo as an example. What do you see in this photo? Most people see an old woman and an old man. But if you really look at it, the old woman's face is actually a man. So her nose is his left elbow, her chin is his left knee, her lips are his waist, her forehead is a pot that he's holding on his head. And if you look at the old man, it's another person playing a guitar. The right elbow is the nose, the right knee is the chin. What looks like a mustache is actually the guitar. And if you look further, you realize his ear is actually a woman standing in an archway. And if you even look further, you'll realize there's a gold chalice between the two of them. And so what happens in dentistry is the more we can see into the patient that we're examining, the more we can understand what has to happen for them. And so if I was to say to you, if this patient walked in, what do you see? And most of you, she's in her mid-50s. She's got pretty well-aligned teeth. She's got a decent occlusion. She doesn't have much tooth wear. This is an easy patient for you to treatment plan because really everything's fine except for the restorations in the teeth might need to be treated. That's very different than somebody like this, who has significant tooth wear and a very deep overbite, or somebody like this that has posterior tooth wear and an anterior open bite, or somebody like this who has significant anterior wear and an end-to-end occlusion. And so what this webinar is about is it's helping you to see in a different way. Because if you can see your patients differently, you'll suddenly realize what their options are for treatment. And a mentor of mine named Ralph O'Connor back in the early 1980s used to lecture all over the country on how to do four-handed dentistry, which was a pretty radical thing in the 1960s and 70s, how to have more than one patient in an operatory, two operatories, multiple assistants, four-handed dentistry. But in his own practice, Ralph realized his method of treating patients only worked for patients who needed single teeth treated. His method of treating patients didn't help these people. So he formed a study club in 1983 that I was part of to have a bunch of us in the community in Tacoma, Washington, help him see differently. So that then once he could see differently, he could realize what had to be done to help treat these patients. And in reality, what this webinar is really about is it's about learning. And there's a big difference between learning and education. Education is basically the giving or receiving of instruction. It's essentially talking and listening. Learning is the acquisition of knowledge or skills. And dentistry is an interesting profession because it requires both. You have to gain knowledge and you have to gain skills. Knowledge we can do virtually, we can do seminars, you can do online. Skills typically end up having to be taught hands-on. And so I'm just going to bring out something we're pretty excited about at Spear, and that is that we've added 2 new laboratories, teaching laboratories at Spear, so that we could manage the number of people that wanted to take hands-on workshops. And because we've just added those 2 new laboratories, we're actually running a promotion this summer between June 2nd and September 30th. And if you actually sign up for a hands-on workshop to grow your both knowledge and skills between June 2nd and September 30th, we will actually cover your hotel stay at the Fairmont Princess. And Tyler's going to actually post information on the chat function about that promotion. But that's something that we're excited about because I totally get it. Dentists need both. It's not just knowledge and it's not just hands-on, it's both combined. And why does that work? Why does that change your practice? Because gaining knowledge and skills leads to increased competence. And increased competence leads to increased confidence. And what happens when a dentist has increased competence and confidence is you suddenly start talking to patients differently. You talk to your team differently. And guess what else? You present treatment differently. And you start getting a much higher level of case acceptance. And so why is it important to me that you learn to treat these kinds of patients? Number one, they need the treatment. They really need the treatment. Treating them can be really fulfilling for everybody on the team. And it can also be very productive and very profitable. Now, what are the obstacles to treating these kinds of patients? The first obstacle is the dentist not knowing what to do. The second obstacle is you have a bunch of patients who are going to say, I can't afford it, which is accurate. But there's other ones that say, yes, I can. And unfortunately, what happens is when a team or the dentist hears, I can't afford it, a lot of times, they start assuming that, in fact, all of their patients fall into that bundle. And so they simply stop presenting treatment. And to me, that's probably one of the biggest obstacles there is when the dentist and the team believe their patients simply don't want dentistry. Whereas the truth is, some of your patients don't want dentistry and others do. Okay. And for sure, if you're talking real complex cases, it's not going to be covered by, quote, their dental insurance because it's a defined benefit plan. There's a limited amount that their insurance is going to pay. Now, I'm actually going to start by talking a little bit about how we present more complex treatment to patients. And so I'm going to suggest that there's kind of 3 models of how we present treatment in dentistry. There's the authoritarian model, the scarcity model, and the co-diagnostic model. The authoritarian model is a really classic model. You have it, I can fix it, $5,000. It's the piece of paper, you developed the treatment plan, you slid it across the desk, here. If you want me to fix it, this is the plan. It's a really traditional doctor-patient relationship. It works actually very well for simple presentations. If you tell somebody they need a crown, they need a filling, it works. Now, the scarcity model is the same model, but with fear built in. And when I mean fear, what I mean is the dentist's fear. As soon as you run into a patient that starts having more than a few teeth that need treatment, the anxiety is, oh, wow, I just met this person. If I tell them everything that I think they need, that's going to scare them away. So I'm just going to pick a couple things now. I'll focus on what their chief concern is. And as I develop trust and a relationship with them, then I'll share these other things I see. The flaw with this model is, in reality, if you share only a few things in the beginning, and then you treat a few teeth, and then a year goes by, and you've seen them a few times in recall, and you treat another tooth, and then another year goes by, and now you think, okay, they trust me, they've been coming for 2 years, and I'm going to tell them about all the other stuff I see. You suddenly find yourself going, but what if they say, why didn't you tell me this earlier? Why'd you wait 2 years to tell me? And suddenly you end up locking yourself into this kind of a tooth-based practice on this patient, as opposed to a more holistic practice. Codiagnosis is a very different approach. In codiagnosis, we don't present a treatment plan. What we present is the findings from the exam. So the exam is very systematic. The findings are presented and the consequences of each finding are presented. We create a vision, if you will, of what their oral health could be. And then we say to them, how would you like to proceed? I can give you my recommendations. And so essentially the key to a co-diagnostic approach is you start by making them aware of what you found. You make them aware of the consequences of doing nothing. And you make them aware of the benefits of treatment. And then you say to them, is this something you would be interested in treating? And most people are going to say, how much will it cost? And when a patient asks you how much something costs, it's perfect because it means they're interested. When people don't ask how much it costs, it's not good because it typically means they're not interested. So the father of codiagnosis was a very famous dentist who unfortunately died young in a plane crash in the 1970s named Bob Barkley. Bob Barkley, in many ways, is the father of modern preventive dentistry in the US. And so he came up with this concept of codiagnosis, getting the patient involved in creating the treatment plan so they own it instead of you creating the treatment plan, which means that you have a lot of anxiety around it. So a very simple example of the authoritarian approach. This is a 75-year-old patient who works doing janitorial services in a prison. She has a very limited funds. She went to her dentist. Her dentist gave her a treatment plan. Full mouth reconstruction, every tooth, 4 implants to replace the molars, $65,000. There's no way she can do that. But when you learn to talk to patients differently and you learn to see and think differently, you realize that patients that have tooth wear, the one thing they have going in their favor is they tend to have tooth wear because those teeth aren't restored. That means you can bond to them. And so this is a patient who came into our office and ended up seeing my partner, Greg Kinzer. And Greg looked at her and said, you know what? You don't need a reconstruction. We can do this out of composite. And so we're going to talk about the facially generated treatment planning system in detail, but effectively it's learning where to position the maxillary teeth, tissue, and papilla, that's aesthetics. Then learning how to alter the mandibular teeth so they function correctly against the maxillary teeth. And then learning how and which teeth you want to restore or replace. And then thinking about, do any teeth need perio, endo, oral surgery, et cetera. So here's her full smile. Here's her lip at rest. She doesn't show anything. We'd like her to at least show 0.5 millimeter or 1 millimeter of tooth, ideally at rest. And so Greg developed a treatment plan that's going to lengthen her anterior teeth. It's going to be done with composite. He mounts models. He does a wax up simulating what he thinks is correct for the anterior teeth. In doing so, she now has no posterior occlusion because the anterior teeth being lengthened have, quote, opened the bite. And now on the models, he can decide, should I equilibrate the lower incisors? Should I add some composite to the posterior teeth? Shall I do a little bit of both, which is what he did? And so here you can see where the wax is added to the posteriors, and the lower anteriors were equilibrated as well to close the bite back down a little bit. And now from this wax up, we generate matrices out of silicone or copyplast or both. And you take a patient who was told the treatment was going to be $65,000, and out of composite, you can do it dramatically more reasonably and get a great result. My oldest case that I have so far treated like this is 18 years out. And the composites, modern nanohybrid composites, are amazing. But you have to see what's happening in the patient. You have to see the outcome in order to know the steps to do the treatment, to put everything in the right place. And what about not replacing the molars? Interesting. This study looked at the related quality of life of patients who had second premolar occlusion forward versus a normal full second molar to second molar occlusion. They followed these patients over 10 years. There was zero difference in their quality of life, whether they had molars or didn't have molars. And so that's where she ends up. But you have to see and think through systematically the steps to get her there. Now, the other thing I want to talk about is profitability of these kinds of cases. Whether you're in network or not in network, we'll talk first about patients who are not in network with you. So fee-for-service patients. So let's just pretend that you charged $1,000 a unit. The ADA says the average general dentist last year has an overhead of 70%. So if you charged $1,000 for a crown, you have $300 of profit. If you were in network, and Delta says they average 20% discount, so we'll use 20%. If you write off 20% of your fee to be in network, you now get paid $800. That means your PPO crowns actually only net you $100 a unit, which means one fee-for-service unit is the same as you having to do 3 PPO crowns. So to put it differently, this patient came in because she didn't like her old veneers. We ended up doing new veneers, going back to the second premolar, so 10 units, it's all fee-for-service. If you were trying to equal the profit of those 10 veneers on patients with single PPO crowns or veneers, you would have to do 30 PPO units to equal the profitability. Those veneers on that patient that I did, that was 2 appointments. If you don't have chairside CAD/CAM, those 30 PPO units are 60 appointments. So one of the ways to become far more productive and profitable is to become more efficient, do more dentistry. You don't have to do fee-for-service dentistry, but do more efficient dentistry. If a patient needs 4 units, do them at once. Don't do 4 units over 3 years if you can, unless the patient absolutely can't do it, because of how much more time it takes in your schedule. So literally, 1 fee-for-service unit, if you can find patients in your practice that are fee-for-service and want to pay for it, 1 fee-for-service unit is the same as doing 3 PPO units. But that doesn't mean that we want you to not have insurance, because being in network allows you to have a really robust patient base. And the beauty of a robust patient base is hygiene. It keeps your hygiene full, which is an awesome thing. But if you can find a fee-for-service patient that wants 10 units, 2 appointments, and I put in 8 hours of time, it's more than I would have needed to do those 10 units. But for you to equal that, doing 1 unit on each individual PPO patient, you would have to have treated 30 patients, 60 appointments. unless you have chairside CAD/CAM. Okay. Even if you are in network, if you do a 10-unit case in network, you're still way ahead of doing 10 units on 10 individual patients. You can do it in 2 appointments as opposed to 20 appointments. And bottom line, when you learn to treatment plan differently, you don't need 10 and 12 unit cases. Just find patients that need 3 or 4 teeth treated and do them all at once. It's so much more efficient. Now, last little bit about talking to patients. This is a photograph of a patient from 1983. I was working as an associate in a practice that had been open 40 years. And this patient had been in his practice 25 years. The patient came in because, quote, he had an emergency. And what the patient believes is he's going to end up with dentures. That's what he's been told. And so what was his emergency? He woke up that morning with a piece of amalgam in his mouth, and he wanted to know where it came from. And it came from a lower second premolar. So you take a look at this patient and you say to yourself, I just met him. I'm supposed to, quote, take care of his emergency. What do I tell him? It's time to take out your teeth and do dentures. I can tell him where the amalgam came from. That's easy. Do I tell him you need a reconstruction? It's X thousands of dollars when I just met him? That'll blow him out of the water. I could tell him you need a full exam, radiographs, mounted models, all those things. But in reality, what I would suggest to you is when you see patients who have more complex problems, you try and help them have a vision of what's possible. You don't even go down the treatment planning road at all. You simply help them see what's possible. In his case, I showed him a patient like this. Here's another patient with a lot of tooth wear. Here he was after we treated him. This is what he looked like before. That's what he looks like after. And then you turn to the patient in the chair and go, would you have any interest in investigating this? And I can promise you, if the patient has an interest, they're going to ask, how much will it cost? And that is a great question, because that means they have an interest. And what I have said for almost 40 years now in practice, when somebody has a complex problem like this and they ask what it costs, my answer is it's going to be as much as a car. And the patient, if they're still interested, are going to say, what kind of car? Every time. And the answer is, that's up to you. It could be a Mercedes. It could be a Chevrolet. If you'll notice, there's no restorations in his mouth. You can bond to all of those teeth with composite. You could treat this patient with composite if you understand how to treatment plan him. What I would then say is, what I can tell you is how much it will cost to find out. Because I'm going to have you back for an exam, radiographs, photographs, mounted models. I need all of those things to develop your treatment plan. And this is how much it will cost for me to do the exam, the radiographs, the photographs, and the mounted models. If he wants to do it, schedule him to come back for the exam, the photographs, the radiographs, and the models. If he's not interested, repair where the amalgam was and send him home. What did he do? He did everything. Would I have ever dreamed that he'd do everything? No, he didn't. The whole mouth. Now, we didn't have dent adhesives and we didn't have the composites in 1983 we have today. So composites really weren't an option for him then because we just didn't have the materials. Today, composites would be an option for him. All right. So when this patient comes into your office next week, where do you start? Where do you start the planning process? Well, you're going to need models, but guess what? Models aren't going to help you with the treatment planning. They're not. They're a tool in the treatment planning. Ideally, you'll make mounted models but they're only a tool in the treatment planning process too. The problem is models have no reference for tooth position. And we need a reference to figure out where the teeth go. Do we lengthen the maxillary anteriors significantly, which looks like it's probably the right treatment plan if you're just looking at models, but as teeth wear, they erupt. So this is what it would look like if you just lengthen the anterior teeth. But the reality is, if those teeth erupted, you may actually need to do some crown lengthening or orthodontic intrusion to move the gingiva apically and not add that much to the incisal ledge. But you won't know that from models. You know that when you see the patient's face. So facially generated treatment planning is the concept of using the face to treatment plan backwards, outside in, using the face to tell us where the teeth go. His lip at rest, his teeth are 7 millimeters under his lip. We'd like him to be 1 millimeter showing above his lip. And so for him, yeah, he ended up having his teeth lengthened 8 millimeters. But the face dictated that. There's the final wax up. There's the final treatment. So that's what facially generated treatment planning is about. And as I said, my first time I ever lectured on it was 1986. It's utilizing the face to determine where the teeth, gingiva, and papilla should be positioned, and then creating the treatment plan around the corrected tooth position. These days, we have to consider aesthetics, obviously function, but we also have to consider airway as well when we do our treatment planning. And so facially generated treatment planning, we call it aesthetics, function, structure, biology, EFSB. We do aesthetic treatment planning first because that establishes maxillary tooth position. Just like you would never set a lower denture before you would set an upper denture. You have to set the upper denture so you know what the tooth position is. Then we can do occlusion. Then we can figure out which teeth need to be restored or replaced and how we're going to do it. And then we can figure out which teeth need endo, perio, oral surgery. Now, this is how we treatment plan. This is not the order in which we treat. The order in which we treat is very dependent on patients. So some patients have some urgent caries needs, et cetera. Some patients have urgent perio needs. So you always treat those things first. But when we plan comprehensive treatment, we plan tooth position first. Aesthetics sets the maxillary arch, function sets the mandibular arch. And then, as I mentioned, airway is a much bigger factor in our understanding today. And so when we really think about it, before we can do, quote, EFSB, you have to have addressed airway. And you don't need fancy screening tools to address airway. You can ask patients some very simple questions. How do you sleep? Do you snore? Do you sleep with your mouth open? Has anybody ever heard you stop breathing during sleep? If the answer to any of those questions is yes, then you might want to go to a more detailed screening in terms of oxygen saturation, et cetera. We also have to assess jaw joints before we can do definitive treatment planning. And that's in the facially generated treatment planning workshop, it's all about these kinds of things that have to be addressed, along with how do you then sequence the treatment planning process. So when we really think about it, what you're trying to do for these patients is you're trying to identify your outcome. What are your goals? What's the outcome we want in our final treatment? And then we go back to, okay, this is what we want. Now let's look at where the patient is. So essentially, we can make it really simple. We want the patient to have 24/7 nasal breathing so that their airway is patent and easily, they don't have to breathe through their mouth. We want them to have pleasing aesthetics. We want them to have acceptable function. That's kind of our outcome, along with all the typical dental things of periodontal health and lack of caries, et cetera. So what I'm going to do is walk you through kind of what is average, if you will. What's the norm for the different parameters we use in setting tooth position? And then I'm going to end by showing you a bunch of cases that are very different cases: open bite, deep overbite, edge to edge occlusion, etc. So we use lip at rest a lot. We use full smile a lot. And then we use some other facial parameters to help us understand where to put teeth. What I need you to know is most research, when they publish conclusions, they publish top of the bell curve. What you and I need to know as clinicians is what's the range of normal? What's kind of range of normal acceptable? Because it's not the narrow part of the bell curve. So for example, the lip at rest of that person on the left, and then the full smile versus, and she's 24, the one on the left, the person on the right is 50. They're both within normal limits, but they're very different looking smiles. And then you have some that are way outside of normal. So this is a 28-year-old guy. He shows 0 teeth, 0. Even when he smiles, he shows no teeth. And then here's a 60-year-old female, the other extreme, has massive lip mobility. So typically, the things I use to help me position teeth is I use tooth display at rest. And how do we get that photograph? There's a few ways to do it. The easy way to do it is ask the patient to say Emma, not just M, Emma. And as they say Emma, they'll open, take the photograph. What's kind of within normal range? 1 to 5 millimeters. Then we look at what we call lip mobility. Lip mobility is how far the lip moves from rest position to its highest point. And in her case, lip mobility is 6. Normal would be 6 to 9. And it is influenced by the position of the teeth labiolingually. We want a pleasing smile line. So once you identify where the centrals go, the centrals pretty much help you dictate where the laterals, canines, and premolars go. The inclination of the centrals is important functionally, but also aesthetically. And since I don't take cephalometric films, because I'm not an orthodontist, what I do is I draw a line along the occlusal plane, and I draw a line along the labial surface of the central, and 85 degrees, and this is easy to measure on a computer. It's super easy to draw these lines on a computer. 85 degrees is sort of a really nice inclination. Anything less than 80, that tooth is probably proclined. Anything over 90, it's probably retroclined. Gingival levels, we want the two centrals even with each other. We want the laterals a little coronal to the centrals. And typically we want the canines even with each other. So her gingival levels are perfectly acceptable. Crown to width ratio, which we're going to use in our treatment planning of these patients in a few minutes. Typically a crown to width to length ratio of around 75 to 85% is within the range of acceptable. The average central, just for treatment planning purposes, is 10.5 to 11.5 millimeters long. Hers happens to be 11. So when you're treatment planning a patient from photographs and models, basically you're just trying to get the parameters of tooth position and tissue position within, quote, this range of normal. Papilla levels, we want them symmetrical with each other. And typically we want the papilla between the centrals, if we measured from the incisal edge apically, we want that distance to end up being 5 to 6 millimeters. And functionally, when the patient bites, we want simultaneous contact on all the teeth. And we want enough overbite that we get disclusion, separation of the posterior teeth when the patient moves. And what restorative dentists often don't realize is the amount of overbite is highly correlated to the amount of overjet. The more overjet you have, the deeper your overbite will be. The less overjet you have, the shallower your overbite will be. So the reason a class 1 molar relationship is very desirable is it creates an overjet that when the anterior teeth erupt, they end up with about 3 to 4 millimeters of overbite, which is a very kind of normal amount of overbite. And then the last thing that I think is really important is you realize that we need facial photos, because oftentimes the patients that really we don't know what to do with, they often may actually have skeletal problems. And by learning how to look at facial photos, we can learn how to assess, is this a patient whose issues are skeletally related? So lip at rest frontal view, full smile frontal view, lip at rest profile view, full smile profile view. And what do we do with that piece of information? With the lip at rest profile view, we go from glabella, which is right between your eyebrows, to the base of your nose, which is subnasally. We'll call that the midface. And then we go to menton, which is the bottom of your chin. And typically, an average midface is 45 to 50%. An average lower face is 50 to 55% of the total. When you see some patients who happen to have really steep mandibular plane angles, gummy smiles, you'll end up seeing the lower face 55 to 60%. When you see real square-jawed patients that don't have much tooth display, you'll see the lower face actually less than 50%. We also then can look at profile. Again, glabella, subnasally, pogonion on the most prominent part of the chin, draw some lines between those places, measure the angle formed. In the typical Caucasian face, the normal is 165 to 175. In the typical Asian face, it's actually a little more retrognathic. In the typical African American face, it's actually a little more prognathic. And then we use something called the Andrews line to evaluate the projection, the AP projection of the maxilla. And the Andrews line is when the patient's looking right off at the horizon. If you drop a line from glabella straight down, we want the centrals right on that line. Hers are perfectly positioned. If her centrals were 3 to 4 millimeters behind that line, we'd be thinking she has a deficient maxilla. If her centrals are in front of that line, we'd be thinking the teeth are proclined or prognathic. And then finally, something you might not have heard of is called interlabial gap. And interlabial gap is the space between the lips at rest. It's that space right there. And the reason interlabial gap is important is because of breathing. We need the patient to be able to close their lips together without straining. Otherwise, they're going to be a mouth breather. So these two photos have been sized identically. You can see glabella, subnasally on each photo the same. Here is the length of her upper lip, lower lip, and if you move those arrows across, she can close her lips together. 0 interlabial gap, no lip strain at all. It's easy for her to breathe through her nose. And then finally, one of the last measurements we do is we look at the transverse dimension of the maxilla. Did the maxilla actually grow correctly? So the distance between what's called intermolar palatal width, a norm is between 37 to 39 millimeters. If it's less than 31, it's really narrow, you probably have a mouth breather, and you're going to need some sort of expansion. All right, so let me just walk you through a few cases quickly to show you how this all works. So here is a young patient in his 20s. He fractured his anterior teeth at age 12. He wants prettier front teeth, class 1 molar occlusion. Easy case, right? Easy case, except he has an end-to-end occlusion. What he really has is inadequate overjet. And so where do we start? We start by identifying where are his maxillary centrals. Where should they be? So he shows 1.5 millimeters at rest. That's not terrible, but obviously as a reverse smile line. His lip mobility is normal. When we look at his face, his mid-face, lower face, and profile are normal. So it's not a skeletal issue. His Andrews line is right where it belongs. So you're not going to want to move those centrals forward. No restorations in his whole mouth. His intermolar palatal width is normal. Canine width is normal. And so bottom line, when we need overjet, and overjet is something we need frequently in these severe wear cases. When we need overjet, we go through, do I procline uppers? Do I retract lowers? Do I intrude uppers that are worn? Do I intrude lowers? Do I do jaw surgery? Do I open people's bites? And so you just walk through the process and you go, well, pretty much this is where I want to put his teeth, but I can't do that because the lower incisors are in the way. So is it because we need to procline the uppers? No, the Andrews line was correct and their inclination is correct. Those upper centrals are perfect. They just need to be lengthened. His gingival levels are virtually ideal. These teeth didn't erupt as they wore. When teeth erupt as they wear, the gingival margin comes down with them. The problem with him is right here. Vince Kokich taught me years ago, he wants to see the labial surface of the lower incisors either equal to bony chin or within about 1 millimeter of bony chin. His lower incisors are 3 millimeters in front of bony chin. And so when we think about his treatment options, are we going to procline the uppers? No. Are we going to retract the lowers? Yes. That's where the that's where the overjet's going to come from. We're going to intrude the uppers? No, the gingiva is right where we want it. The width to length ratio, once we restore them, will be right in our 75 to 85% range. Are we going to intrude the lowers? No, they didn't erupt. They're just too far forward. We're going to do jaw surgery? No, his facial profile is normal. And in terms of airway, I think of treatment planning, anything that narrows the mouth, so makes less room for the tongue, I typically think of as airway unfavorable. Anything that expands the arch, makes more room for the tongue, I think of as airway favorable. I would call his airway neutral because his maxilla is in the right place. And the amount we're going to be changing the lower incisors is really minor. So how did we do it? Vince Kokich Sr. did the ortho. Vince is going to do some stripping between the lower anteriors right there. Each of those embrasures is going to get open so he can do some minor retraction. He brought them back 1.5 millimeters, perhaps. And now I have the ability to go ahead and prep the 4 incisors and put my provisional on. And so this case, which looks like a really complex case when you first look at it and you're walking around with models in your hands, it's a simple case once the tooth position is corrected. So there's the provisionals, there's the final result. All right, more complex one, end-to-end wear again. So the challenge of end-to-end cases is oftentimes they end up class 3. And the problem with class 3 or tending to class 3 is you lose overjet. When you lose overjet, you can't have any overbite. This particular patient, if we go through and we look at all his variables, we look at his face, put on all our parameters, his profile looks perfectly normal. His vertical face development is perfectly normal. Interestingly, he is class 3 dentally. And this is a patient we treated before we had the knowledge we do today of airway. In many ways, if this person did have sleeping or airway problems, we would have thought about treating this patient with a maxillary advancement. Back when we treated him, we weren't as into airway. But what I want you to notice, his posterior teeth have virtually no wear at all. His wear is only on the anteriors. And he's missing 1 lower incisor. If he had all his lower incisors, he literally would have been full class 3. But because he's missing the 1 lower incisor, he actually is more end-to-end. So what's our outcome we want for him? That's it on the left. We want a normal overbite overjet relationship for him. That's the desired outcome. If we saw him when he was 16, he probably looked about like this. And what happened is as he wore his anterior teeth did what they do, they erupted. And then they continued to wear. And so what we're going to end up needing is we need to put the teeth back in position, but we need overjet. Otherwise, we're stuck in this end-to-end relationship. So we need to move the upper anteriors back where they belong, the lower incisors back, intrude them, and retract them. Then we can create the ideal for him. And it's just the same steps. It's always the same steps. So evaluate the central incisors. That's his full smile. Lip at rest, you can't see the centrals. They're even with his lip. His lip mobility, totally normal. And so the decision was made to add about 1.5 millimeters to the incisors to get them level with the occlusal plane. And are we going to procline the upper incisors? Yes, they're over 90 degrees. So they're going to get proclined. Are we going to retract the lower incisors? Yes. That's where we're going to get our overjet. Proclining the uppers, retracting the lowers. Are we going to intrude the uppers? Yes, they have erupted significantly. Look how short they are. Even if you add the 1.5 millimeters to them, they're super short. So if you add 1.5 millimeters, his width to length ratio is 94% for the right, 101% for the left. So what's going to determine how much you intrude? Gingival margin position, so that you end up with a pleasing width to length ratio. We're going to intrude the lowers. Yeah, look at how far they've come up. And so basically, not going to be a jaw surgery case, not going to be an open the bite case. It's going to be treat the position of the anterior teeth. And the beauty of it ends up being, again, you can restore them with composite if you want. Now, what if he says no to ortho? Well, crown lengthening could correct the gingival position and tooth length, but it's not going to correct the occlusion. He's going to still be end to end. There won't be any overbite. And the truth is, if you want to treat him so it looks better aesthetically, you could crown lengthen him and restore him, but you're going to have to restore the whole upper arch. So it's an easy case to present to the patient because of cost. Ortho and some composites, or ortho and a few restorations, dramatically cheaper than the full mouth. So Vince is going to take out one lower incisor, not touching the posterior teeth. Today, I would say it's an airway unfavorable treatment plan because we don't know what his actual breathing issues are. So here is what it's going to end up with. Lower incisor taken out, retracted, restore the 2 lower incisors that are left, intrude and restore 4 upper incisors. He's going to end up being treated with ortho and 6 restorations. So there's the intrusion of the maxillary anteriors. There's the space created. Vince takes the brackets off. We do a 1-shade composite to create the teeth the right length. Vince puts the brackets back on, finishes the ortho. The beauty of this is you get to test drive the occlusion in composite for 6 to 9 months while the ortho is being finished. And he could stay in these composites for years if he wants. Now, he didn't. He converted to porcelain, four porcelain restorations in the maxilla, 2 on the lower incisors. But what looks like a full mouth rehab on the left is simply a tooth position problem. He doesn't need his bite opened, doesn't need any of that. And you find all of that out as you go through the treatment planning system. Now we'll go the other extreme. Deep overbite with what we call pathway wear. Pathway wear being wear on the palatal of the upper anteriors, facial of the lower anteriors. So there's the depth of overbite. Look at the wear on the upper incisors. Those lower incisors fit perfectly in there. So all the same, every case is the same. The steps are always the same. Go to the face, He actually has a fairly prominent chin, so his profile is a little flatter than what most would be normal. His vertical facial development is normal. He has a class 1 molar relationship on each side. He has no wear on his back teeth. This isn't a vertical dimension problem. This is an anterior tooth position problem. So again, there's the outcome. That's what we're trying to achieve right there. If we'd have seen him when he was 16, we probably would have seen somebody that looked like this. Very upright or retroclined anterior teeth, deep overbite. And a lot of people can live fine like that. He didn't. He created wear on the palatal of the upper, facial of the lower. And as those teeth wore, they erupted down and up. And so he's basically already prepped the lower incisors on the facial. He's prepped the upper incisors on the palatal. There's no way you can prep these teeth. And the trouble is you can't open the bite. Well, you can, but you end up with teeth that are way too long in his face because they've erupted down and erupted up. And so in reality, ideally, it's an ortho case. So we'll walk through our parameters. His lip at rest, there's no tooth display. His upper incisors are even with his lips, so you don't see anything. So the good news is you don't need to add much. Millimeter and a half to the incisors gets you nice level occlusal plane with the canines and premolars. Right? The upper incisor inclination, it's the opposite of the previous patient. They're way retroclined, like way retroclined. So yes, they need to be brought forward. Gingival levels, they're not bad, but since you're going to be moving the anterior teeth, they're going to improve anyway. The lower incisor position, look at where they are relative to bony chin. They're way back. This isn't a case of teeth needing to be retracted. The problem with the lower incisors in this case, they're too tall. At rest, you can see 5 millimeters of lower incisor. And they're short. If you restored them to a normal length, when he smiles, all you would see is lower incisors. That's why opening the vertical to gain space isn't going to work for him. So are we going to procline the uppers? Yes. Are we going to retract lowers? No. Are we going to intrude uppers? Yes. And what's going to determine how far? Width to length ratio. You're going to intrude them to get your nice 75 to 85% width to length ratio. You're going to intrude the lowers. Oh, wow. Look at that. His lower gingival margins are even with the posterior occlusal plane. If you were to try and restore his teeth and then open his bite, look how tall the posterior teeth would end up being. So that's going to be the treatment plan for the lower incisors. And it's going to be like 5 millimeters of intrusion. It's a bunch. So what if he says no to ortho? Well, if the roots are long enough on the lower anteriors, you could try and crown lengthen them. Otherwise, you could extract them and do an FPD between canines. Otherwise, you could extract them and do implants. And so the trouble with extraction and implants is this. The implants would need to be here. The current bone is there. Whoever does those implants is going to have to take off that much bone. Otherwise, you're going to end up with essentially implants that are over-erupted. And as far as the maxillary anteriors, so intrusion's the ideal for the lower incisors. As far as the maxillary anteriors, they're really challenging because of how retroclined they are and the palate's already prepped essentially. And no, not going to be any orthognathic surgery. And the ortho in this case is going to actually be airway favorable. It's going to bring everything forward. So here's the real problem. If he says no to ortho, that's where his centrals are now. This is where you want them to be. If we marry those two images, if you were to try and keep his centrals and prep them, you basically end up with no tooth structure and probably endo. And so his upper incisors, if he doesn't want to do ortho, his two centrals may end up needing to be extracted and replaced with implants if he doesn't want to do the ortho. So bottom line, he said yes to the ortho. There's the intrusion, building up the lower anteriors first so that Vince could put his brackets on and intrude the lowers. And you go from now built up lower incisors level with the occlusal plane versus before the gingival margins being level with the occlusal plane. And if you'll notice in the final result, Vince left about 1 millimeter to 1.5 millimeters open bite so that there's no need to prep the palatal of the upper anteriors because the patient already prepped them. And again, this is a case that could be treated with composite. And how do we know that the vertical dimension didn't open up? Because with before and after cephs, the distance from maxilla to mandible didn't change at all. It was intrusion of the teeth. So we ended up with 2 central crowns and 4 lower anterior veneers. So a case that looks impossible to treat. Once you go through the system, you realize 6 restorations and the patient's happy as can be. Okay, last patient, anterior open bite, missing her 4 incisors. She's got significant posterior wear, class 3 molar relationship. And so here you can see she's biting, posteriors are in occlusion, but the anteriors are open. When you have an anterior open bite, you have some choices. You can lengthen lower incisors, you can lengthen upper incisors, you can shorten maxillary posteriors, you can shorten mandibular posteriors. And if I gave you an articulator and said, here, close her open bite, you'd be going, I'm not sure what to do. Correct, because you don't have a reference. So what's our reference? It's her face. So let's go to her face. Interesting. She actually has a class 3 profile, 185 degrees. Her vertical development's fine, but 185 is a definite class 3 profile. Also notice how much gingiva she shows in the posterior of her smile. Look at the wear on the posterior teeth because they're the only things touching. So she's worn through some old provisional restorations. Her intermolar palatal width is actually normal. And another way to measure it is measure the canines. And typically what you're looking for is between the molars, you want it 1.1 times what the inner canine width is. Now we go to our kind of standard references. Tooth display at rest, quite good. Lip mobility, totally within the range of normal. Her central incisor position is actually pretty decent. You put in the laterals, you put in the canines, and her maxillary anterior tooth position is not bad at all. It follows her lip quite nicely. Now let's draw in the posteriors. Totally different. Now suddenly she has a reverse smile line. So how are we going to correct the reverse smile line? Well, I can promise you, if you set this case to a lab with a set of mounted models but no photographs, I can promise you, here's what they'd do. They'd lengthen the 6 anterior teeth to match the posteriors. And if you put that in her face, it's a 62% width to length ratio. And the amount of tooth display at rest would now go up to about 7 millimeters. And your central incisors are now 14 millimeters long, and it's going to look terrible. The problem in this patient is the posterior teeth. Her anterior teeth position is fine. And so what's our option? Change the posterior tooth position. Then you get a pleasing smile line. And again, all of this is just learning what to look at in sequence. So in reality, her posterior occlusal plane needs to be on that green line. And how are you going to get it there? Well, you could use mini implants and intrude the teeth. Crown lengthening, her roots aren't that long. Orthognathic surgery could do it. Extracting the teeth, placing implants could do it. Remember her facial profile? She was class 3. Dentally, she's class 3. What's the correct treatment plan for this patient? It's orthognathic surgery. And so it's airway favorable. And Roger West, the oral surgeon, Vince Kokich did the model surgery for me. So they're going to impact the maxilla in the posterior and then move it anteriorly into a class 1 relationship. From their model surgery, I had a diagnostic wax up done. From that, I had provisional shells made, and I measured the distance from cusp tip of the canine on my wax up to gingiva, cusp tip of molar to the gingiva on my wax up. There's my shells. Prep the upper, use those measurements to reline the shell correctly to match the wax up. Then did the same thing on the lower. And it looks strange as can be, but that's her occlusion. When I was done putting the provisionals in, that was on a Wednesday. On Friday, Roger West did the orthognathic surgery. Now her occlusion fits. But the treatment planning system, in this case, was treated over about a 12 to 18 month period. The treatment planning system never changed on any of the patients I'm showing you. It always stayed the same. So last thing I would leave you with is, I've been doing this for a really long time, like 40 years. And in terms of education. And so I hear very frequently 2 common fears about taking hands-on workshops. The first fear is the dentist says to me, I'm not ready yet. I'm not experienced enough yet. And my response is, exactly. That's why you want to do a hands-on workshop. Grow your skill level, grow your knowledge base. And the second thing I hear is, I can't afford it. So I'm going to leave you with 2 emails from your peers, because it's better that you hear it from them than me. So the first is an oral surgeon who leads a study club, a very, very analytical oral surgeon, does primarily implants. And so he came to the facially generated treatment planning workshop with 7 of his general practitioners. And just by the nature of personality, he decided that he would track their referrals for the next 12 months to see if the workshop had any impact on what they referred him. And in the next 12 months, those 7 general practitioners, their referral rate to him went up 64%. Now, I want you to think about the fact that what does that mean those people are doing in their practice? That means their implant practice went up 64%. That's amazing, honestly, from one workshop. But I will tell you, the facially generated treatment planning workshop is the most transformative workshop in our entire curriculum, because it teaches you to see differently and it teaches you the skills you need to do the exam, to work up the case. And then this is one of my favorite emails I've ever gotten. So it's from a general practitioner from Boston who just told herself, she says, I can't afford workshops. So for 10 years, she took seminars because she couldn't think she could afford a workshop. She sent me this email. 2 years ago, I took the leap and I started with facially generated treatment planning. Then I did occlusion, then restorative design. Last year, my accountant wanted to know what was going on. My production from 2 years ago is up 100%. My accountant's new mantra is, you must continue to take spare workshops. Thank you. Now, I'm not going to tell you that everybody's production is going to go up 100%. I would never promise that. But I can tell you for 10 years, she did seminars, which is knowledge-based. But it wasn't until she did skill-based learning that she really was able to apply it in practice. So I would urge you to consider the promotion we talked about in the beginning of if you sign up for a workshop between June 2nd and September 30th, we cover your costs. It's an awesome opportunity for you to see the new facility we just added in Scottsdale. And it's really been a pleasure for me to have the time to present with all of you. But with that, I'm going to turn it back to Tyler.